Welcome to the Java Cafe, Java fam. Good morning. Welcome to the Java Cafe, Java fam.
Good morning, everyone. Good morning. It is Tuesday, November 9th, 2021, and we are here in the Java Cafe. In the past year or so, we've done Testimony Tuesdays on Tuesday, but as you know, we are in a partnership with the Massachusetts General Hospital Office of Equity and Community Health, and we are definitely grateful for that partnership to come to you today with our second episode of Your Healthy Java. I have a wonderful young man that's going to come into the room and talk with us about getting back to care. That is today's subject. And so I would like to introduce to some and present to others our medical director of the Your Healthy Java Partnership, Dr. Claude Alabre. Welcome back into the Java Cafe. You were slowly, but no, you're becoming family and a Java bro, as they call it. But good morning, sir. How are you?
Thank you. I am well. Thanks, Jimmy. Good morning. Good morning, everyone listening, old and new. And so,
So we began our session last time, and we just talked generally about some things around COVID, and we weren't able. One of the things, everyone, about Your Healthy Java is that you are able to, at the end of the presentation, during the presentation, but please wait till the end so I can keep up with the questions. You're able to ask questions in real time, and where we can answer them as best we can, well, where Dr. Alabre can answer them as best he can, he will. And then where he needs to get back to us, he will as well. And so, Dr. Alabre, there were a few questions from our last session that were remaining, and I'm just going to get them open here to make sure I have them ready. But let's go. I remember one of the first ones was a question about, is there something called a mu variant? Can you talk a little bit, a couple of seconds about that?
Just a little bit. So yes, there is a mu variant. And so one of the interesting things we mentioned at the very beginning when we started this is that this virus is mutating, is going to continue to mutate. And when it's mutated differently enough, when it acts differently enough, we'll start to have different names. And so the CDC actually has a list of different categories for the variants, what they call variant of interest, variant of concern, variant being monitored, and variants of high consequence. And so basically all I can say right now is that the mu variant is still in the variants being monitored category. It's not being labeled as a variant of high consequence. And so that means like our therapeutics, our approach to caring for someone who may carry it hasn't changed, and the spread is not all that well known. So it's basically being monitored, and we will know more as more comes out.
Okay, thank you.
Or there may not be more that comes out. Hopefully it goes away.
I was excited to say that. Hopefully the update is that the mu variant was not enough to really give a lot of attention to.
Exactly.
One of the other questions remaining was, if you have had COVID and have built many antibodies, is the booster necessary? And so a couple of things there, just in reading it, built many antibodies. You may not know how many antibodies you have. I mean, but I'll let you answer as the
Sure, yeah. So this is another thing that's also being evaluated and studied. We do know that when we get exposed to viruses or vaccines, we build antibodies. That's sort of a normal reaction unless your immune system is completely shut. But that's for the most part not the case. So you will build some antibodies. So people who had COVID typically will build antibodies towards the virus. The big question is, how long do they last, how effective they are, and all that stuff. So there's still data coming out as to how long someone who's had immunity from the virus itself will continue to have immunity. There's basically different number of months being reported, 3 months, 6 months. The latest I read was maybe 8 months. So I don't have a definitive answer on that. No, I don't think anyone does. I mean, again, I'm reading what the scientists are doing and sort of reporting back in a sense. And so right now, the decision from the CDC, the recommendation is that you should get the booster regardless of whether you had the virus or not, because it is believed, and there are some studies coming out now showing that the immunity you get from the vaccine and the booster last longer or better than the virus itself. And so, again, that's the latest development. And so the recommendation is to get it. And that's what we want everyone to do, because it's not going to harm, that's for sure. So, and the duration is not predictable right now for the virus, and we have better sense of what the booster will do.
One of the good things that's indicated in the way they frame that question is if you've had COVID and have built many antibodies, is the booster necessary? It's sort of implied that they got their shot, their vaccine, though they had COVID and may have antibodies. So I just wanted to name that because they said went right to booster. So the presumption is that they still hopefully got the vaccine.
Gotcha. Yeah, right. Exactly. And so, I mean, it doesn't really change too much because we know the same way that your immunity will wane over time with the vaccine, it also does over time with the virus. And so the booster is still necessary to keep that response up so that you're still protected.
Okay. Thank you for that. And then our last question from the last session, because we're committed to getting back to you if we can't answer all the questions, is will the vaccine become an annual dosing like the flu vaccine? And I'll just say, not being a medical person, maybe Dr. Alabre doesn't know because they're still studying. Am I right?
I do not know. We need time. We need time. Just like we didn't know if the booster was going to be necessary or how long after the vaccine, because it needs to be studied and it hasn't been around long enough to know. There's lots of studies ongoing looking at sort of assessing that response, assessing the antibodies in your body, see when they go away. And so we will know when we know for now.
Okay. And one last question in the realm of vaccine. And Dr. Alabre is very honest about the fact he is not a pediatrician, and we'll do our best to keep these sessions up with urgent and current issues in the medical field. But a little bit about, when we last talked, the PD or pediatric vaccine for children was in process of being approved. And then it went to the first step, which was, I believe, the CDC or FDA, and then the FDA proposed that it's okay to pass it up for full approval. And since we've last been together, they have received full approval. Thousands of children have been vaccinated. And so where with what you can you just talk for a couple of seconds about that approval and what maybe not even from a physician, but from a dad's perspective, how you feel about it?
Yeah, so again, I'll just quickly review the process in terms of how approvals come about. And so, again, the vaccine makers, in this case, Pfizer, obviously goes through all the different steps of studies, phase 1, 2, 3, all the clinical trials are done and actually show that the vaccine works and that it's safe. And then when they are ready to and feel comfortable that they have all the data they need and they submit it to the FDA. The FDA, you might have been referring to the advisory committee, who again reviews all the data, make sure everything is up to par, and then finally makes the recommendations. And that FDA approval as the Food and Drug Administration of the country is the authority to say that this is safe to use and it is effective. Again, effective and safety are the top key priorities. And once they prove that is okay, then they submit that to the CDC as the authority, again, in infectious disease control for the country. They then will, again, review all the data, but also the next step is this the right thing for us? So they sort of like, okay, good, it works, it's effective, but is this what we need right now? And so they then also will tell us how do we use it, because they're the ones who tell us how to control diseases and how to stay safe. And so the CDC then did approve that it is safe, it is effective, and it is necessary. It's important. The benefits outweigh the risks. That's sort of like the last sort of bit as well. I mean, that's all been part of the process, but the CDC really focuses on, is this sort of worth it? Are the benefits greater than the risks? Because we do know there are risks with everything. Again, like we said, in life, there's risks for everything. And so right now, there's lots of different data out there talking about vaccines that we've used for kids for many, many, many years that actually are less important than this vaccine, despite the fact that kids are do well with the virus. They are less likely to have severe illnesses, severe diseases, and die from the virus. But there are the very few that do get very ill and very sick and die from it. And that's obviously devastating in any case. And so the risk benefit balance has to be looked at very carefully. And so all I can say, again, as you said, not being a pediatrician and not being an infectious disease doctor, is that the data is telling us the benefits outweigh the risk. And yes, as a dad, my kids will get it. I unfortunately have one who's still too young, but and so I have my 7-year-old all signed up. And so that's happening because we do know, again, the benefits outweigh the risk, and this is what we do. And actually, there's some data out there that says the benefits from the risk of severe complication and dying from COVID in kids is higher than the next 3 viruses that we vaccinate kids for.
Say that again,
but
break that down in layman's terms, because it caught me for a second. So
yeah. So basically, the benefits that you're getting out of the COVID vaccine is greater than the benefits you get from 3 other vaccines that we commonly use for kids combined. So you are more likely to have very bad outcome from COVID virus itself if you're not vaccinated than you are to get from I believe I don't want to say the wrong thing. I think polio was on there. Some of the things that we do every day. So again, it's just like really telling to know that these are things we don't even blink an eye about, that we do every day and are required in some cases for schools and daycare. And they're actually not as critical as the COVID vaccine is. So that's really for me, the biggest point here.
Dr. Alabre, thank you so much for reviewing those last questions. If you're tuning in, we're going to ask you to hit the share button because there is so much pertinent information that Dr. Alabre is sharing in layman's terms, and we're getting real-time information from a doctor, not a website. There's some credible websites, but we're getting real information from a doctor who is at an accredited hospital, affiliated, a teaching hospital with Harvard Medical School. And so please hit share so folks can get real-time information. Dr. Alabre, while the vaccine is stopping or decreasing the impact of COVID-19, there are still concerns. There are still people getting it, either, breakthrough cases or whatever. But one of the other things associated with COVID-19 is the fact that about a year ago, we saw that our numbers were getting ready to rise, and hospitals were closing. You could only go if you had, certain conditions. Elective surgeries were, kind of knocked off. And so we're talking today about getting back to care. And so before I give you the stage for that, we want to share a video with you from Massachusetts General Hospital that really encapsulates what we're going to talk about in just a few moments. And I'm pretty much sure I have all the tech together here. And so we're all set, and cross your fingers, and we'll see you in a couple of seconds.
Too many people, far too many people are delaying important preventive screenings like mammograms and colonoscopies and follow-up care during COVID-19.
Lung screenings with low-dose CT scans can detect cancer in its very early stages when there's much we can do.
Well, child care visits are important for boosting confidence and development, keeping vaccines up to date, and screening for mental health and other issues.
During the COVID-19 pandemic, many people have been delaying life-saving colonoscopy screenings, putting themselves at risk.
I see the difference a mammogram makes. Finding the disease early is the key to cure.
Pap smears reduce life-threatening cervical cancer by as much as 90%.
Regular skin checks are critical for catching skin cancer early, even during COVID-19.
Regular glaucoma screening, comprehensive eye care are critical for preserving healthy eyes and vision.
Staying active is an important part of your physical and mental health, especially during these uncertain times.
During COVID-19, it's particularly important to receive care from experienced experts. When you're pregnant, you need care suited to your own circumstances and a team who can answer your questions and guide you to a healthy delivery and baby.
When we catch disease early, we greatly improve your chances for a complete and successful recovery.
We are here to help.
Your health and safety are
Our highest concerns.
Our highest concern.
our highest concerns.
Please do all you can to take care of yourself and your family.
Visit massgeneral.org to schedule an appointment today.
So that sets sort of some context, Dr. Alabre, for why we are here today. And can you just give us a little bit of context about, why the decisions were made at some points for hospitals to, have to close to keep, people safe at that time? And while you're doing that, I'm going to get your PowerPoint queued up. There's some things we can't avoid with the tech, and so we're going to take care of that. Right
Sure. So yeah, I mean, there are two big reasons. Obviously, the pandemic was new. There's a lot to learn about it. And we barely knew how to even behave and react, what to do. And so you have to take measures that would assure the safety of the patients that were in the hospital and the people that absolutely needed to be there. And there was also a concern about volume. There's only so many people you can have in a hospital at one time. And so decision...
Before you go on, it speaks to how selfless the staff and physicians and whatnot are, but you did not name the safety for you all as well. And that is a factor as well, that there was a consideration taken for the medical staff safety as well. So I just wanted to name that. You went right to the patients. Sorry, go ahead.
I appreciate that. But yes, we do sometimes see ourselves sort of selfless or almost invincible. We're not. But when you're in the throw of things, you just couldn't do what you need to do. I mean, we are in the business of saving lives and helping people, and very few people really hung their hat when the pandemic started. I mean, everyone stayed around and did more. And so, but yes, it was a concern. And so the hospitals had to make decisions, and not even just hospital level, even at the state level. You remember the governor had to sort of publish certain recommendations and guidelines as to what gets done and what got shut down, because we had to accommodate for the volume and figure out how to best do this. And so, yeah, it's been a year and a half, so that's not quite the case anymore, luckily. And so we can talk more about where we are today and what can be done and what needs to be done.
Okay, and we're going to go ahead and get your presentation queued up here. And so there we go there. And so safety first doesn't mean care second. What does that mean, sir?
Yeah, I mean, I just stumbled on this on the internet. I did not say it. As you see there, Health Partners is a health organization in the country that actually put that on their website. And I thought it really meant a lot, and it resonated with a lot of what we're talking about today, which is that safety first does not mean care second. I mean, we talk a lot about safety first, and we just heard it in that clip we played about safety and care being together. We can't separate those two. And so just because we want everyone to be safe, we want our staff to be safe, doesn't mean we're going to put care second. Care has to be right there, hand in hand with safety, and we can do it. We have shown that we have the ability to maintain safety and continue to provide care at the same time. So I think this is really... This summarizes basically what we're talking about today, is that we can do this in a safe manner.
Awesome.
And so, yeah, I mean, I wanted to also sort of show that this whole idea about not giving up on your routine care just because of the pandemic is all around. And this is just sort of showing, we saw the clip from Mass General. This is a statement from a doctor from Georgia, again, talking about even taking it one step further, specifically calling out different diseases that are way worse. And I'll just read this part. The risks posed by ignoring heart attack and strokes are far greater than the risks posed by COVID-19 and seeking care. So the last thing we would want is for someone to feel that they might be having a heart attack or a stroke to say, hey, the hospital is a scary place. I shouldn't go there because I might get COVID. No, that risk is a lot worse. And we don't want anyone to think that you could possibly be suffering at home alone or thinking that you're having a very life-threatening condition and think that you would be at higher risk of getting COVID or getting any complications from COVID than you are from the disease we're experiencing. So we want everyone to know that. And again, bringing it a little bit closer to home, this is Dr. Jacobs from Boston University School of Medicine, who agreed with Dr. Kuhl from Georgia, saying that that holds true even in cities. And this was a little bit earlier in the pandemic when hospitals started to reopen, saying that even in cities that were hit hard, like Boston was, that it is still safer, it's still better to go to the hospital when you need to have your problems taken care of than to stay home because of fear of COVID.
Dr. Alabre, a lot of this, I had an impression that we were going to, talk about the prevention, and we are. But what you just read there leads me to a question that, are you aware of any cases where patients have come in post? Because if you read that statement, the risk posed by ignoring a heart attack. So that means there was a heart attack, there was a stroke, and patients, you have some awareness that patients, because you can do medical tests and come in and see certain chemicals in the blood that indicate that something happened. Has that been the case?
That has happened. Yes, that has happened. I didn't put the numbers there. I didn't want to bore anyone with lots of numbers, but there is lots of data out there showing the reduction in cardiac admissions, in heart attack admissions, people getting fewer cardiac catheterizations, or even emergency visits for chest pain and stroke symptoms. And we do know that heart attacks and stroke didn't go away. So seeing the reduction in number of visits and all that stuff is really telling us that people are not paying attention to these things, or partly for fear. Obviously, that's not the only factor, but we do know that there are published data that shows that people have afterwards reported that the only reason they didn't show up to the emergency room is because they were afraid of COVID. And so that exists, yes. And I still, to this day, unfortunately, have patients who have conditions, they call in for symptoms that you believe they should be seen for and examined and appropriately evaluated and managed. And they decline to come in because they are afraid they might get COVID if they come to the clinic. Forget about the hospital or the emergency room. And so we are experiencing this. And this is the reason why we talked about doing this segment, is because we don't want anyone to miss out on these obviously critical situations, but also we'll talk a little bit about preventive care where you may not even be having symptoms, but we'll talk about the reasons why you don't want to also ignore these problems, because it makes a difference to be seen routinely and have these things looked at before it becomes an issue.
Proactively.
In some cases.
Absolutely.
So yeah, I mean, this is again just to say that, bringing it even closer to home, since I am at Mass General, and obviously there has been statement released by the hospital, and as you saw the clip as well, where everyone believed that even in this pandemic, that your care matters and that we cannot actually ignore your routine care or your urgent care because of COVID, and that your safety is at everyone's highest level of priority, but care does not come second despite that. And so, yes, we are open and we are seeing patients for routine care and urgent care. And we'll again talk a little bit more, and I'd like to hear people's questions later to know how we can help people feel better about being able to do these things safely and appropriately. So I thought I'd actually illustrate a little bit what we're talking about. And this is sort of going a little bit more into the routine care part, not so much urgent care where you think you're having a heart attack. And so this is from the National Cancer Institute. And the point I wanted to make with this slide is to show that at the top, I don't know if people can see it well, we're looking at cancer of all types in different racial groups, ethnicity. And so you can see, since part of this, just to digress a little bit, part of this, the reason we're doing this is to really address the inequity in care for our minority populations, that we do know a lot of people are not getting the care for either access reasons or understanding, lots of different factors, but we do know there's a difference in care for different ethnic groups. And this slide really illustrates well how the number of cancer cases for Blacks, whites, in all races is actually not that different. If you look at the numbers up there, for Blacks, we have 445 cases per 100,000, and then 400, I'm unfortunately not able to see this fully, but it's just
460.
What's that?
460 for white.
For white, yep.
Yep.
Perfect. So a little less for Hispanics and Asians and whatnot. So if you look at white and Black, it's a little bit very close. But if you look at cancer death rates by race and ethnicity, look at how now Blacks all of a sudden take the lead. Not a good lead, not the lead we want to take, but it is a lot more. We're talking about 173 cases per 100,000 versus 153 cases per 100,000 for whites. That's a big difference. And so we have to think and question, why is that? If we're getting cancer at about the same rate, why are Blacks dying more of cancer than whites? And we do know there are data out there. Access is an issue. Big issue. Lack of screening for many reasons, either access or, again, as we're focusing on the health education part, we do know that health education is one of the reasons why sometimes people don't get their screening and may end up dying of cancer more than people who are actually educated on it and have access to it and do it. Because yes, early screening, early detection can make a difference, and we will illustrate that a little bit later.
So one quick question: early access and information and education was an issue pre-COVID, during COVID, and so there's that E word that we've all talked about that move in equity spaces. The other E word is exacerbation. So these things were exacerbated during COVID. So I'll go to the next slide and not go too deep. And what we'll do from a tech point, because I got a text already saying, "Can you make it bigger?" We cannot, but Dr. Alabre and I will work on making the info bigger in the slides in the next presentation. And there, next slide.
Again, so this is to get to the point we were making earlier about early detection can make a difference in survival. And so this slide shows you the likelihood of being alive at 5 years after cancer diagnosis versus your chance of dying after diagnosis. And this is relative risk, which means that what's the chance of you being alive at 5 years after diagnosis of cancer versus someone who does not have cancer? Okay. Yep. And so if you get cervical cancer in this case, and obviously someone else, same age, same profile, doesn't have cancer, what's the chance of you being alive after 5 years of that diagnosis versus that person who didn't have it in the first place? That's what this is referring to. And so what it's showing further is that if you are diagnosed when the cancer is localized, meaning just a small little area of that cervix, you have a 92% chance of being alive at 5 years. If the cancer starts to spread, but only regionally, meaning just a small area outside of that initial cancer, your chance drops to 58 from 92. If it's distant, meaning that it's now spread beyond the cervix, there are organs outside that are already getting that cancer, what we usually call metastasis, your chance drops to 17. That is a huge difference, from 92 to 17% chance of being alive at 5 years. And so that's why, again, we do know that early detection can make a difference. And I do have to say that this is not the only reason. Early detection is not the only reason. Every cancer has different behaviors, and in some cases it may not make a difference. But we do know that in a lot of cases, catching it early makes a huge difference. And so I won't get into all the details of all the other factors that come into play, but I want you to recognize that detection matters. And this is part of it, why it drops from 92 to 60 to 17, because if it's early versus late, your life is in a whole different sort of trajectory.
I just wanted to sort of recap. One question before I recap is SEER stage. What does that stand for, Dr. Alabre?
So that's the society that determines stages of cancer and survival. I just blanked on the actual definition of SEER, but so this is saying that the society that comes up with those numbers. Now, if they combine all the stages, meaning localized, regional, and distant, your overall chance of being alive at 5 years is 66%.
Okay. And
so that's taking into, so if you take all the people, regardless of stages.
Okay.
Okay.
Yep.
So when you get diagnosed, you can be localized, regional, or distant. But if we take all these numbers all together, it's not as telling, but we do have it, so we're showing it. But if we take everyone together, and in a sense, it's telling because if we take everyone, it's 66%. But if we only take the localized cancer, it's 92%.
Got you. Got you. And so just to recap, localized, and you use the cervix, for example, but let's go to the lungs because that's very a very high rate within Black and brown communities, I believe. Right. And so it started out in the lungs. That's localized. If you get it addressed early, 92% of you being around 5 years later. If it goes beyond the lungs into other parts of the respiratory system or your chest, your percentage drops to 58. But then if it gets all over your body, or it starts to go distant out, because I just wanted to recap these terms to make sure that people are understanding.
Yeah, sure. And it's a little different. The numbers are not going to be the same for lung versus cervical cancer. I think I have another example there, but it does show that the chance still drops as it spreads more. And so localized typically means like a small little area that sometimes can be sort of, when we talk about margin, sort of like there's a capsule around it, it hasn't actually opened up to other places. In the case of the lungs, regional would mean like it goes to other parts of the lung. So you have more than one focus of it, one little pocket of it. And then distant means that it goes to the lymph nodes, to the brain, possibly depending on the types of cancer. Prostate cancer can go to the bone. So different cancers will spread differently, but basically, when it's beyond the organ that it starts out of or that it comes from, basically.
And that's when it goes into regional and distant. And thank you for the clarity, because it says right there, you were talking specifically about cervical cancer. Okay.
Yeah, sure.
We'll go to the next slide. There you go.
So again, sort of talking about the things that we do before you have symptoms, before anything comes up that you don't want to ignore. And so for colorectal cancer screening, which is actually one of the best screening methods we have. And the reason for that, we are catching what could become cancer, not actually cancer for the most part. There are cases where obviously you may get that, but the ideal screening method or approach for colon cancer is to actually catch something called a polyp, which is a growth in the colon that is not cancer yet, but has the potential to become cancer. And in the second paragraph there, it talks about some of those may take 10 to 15 years to develop into cancer. And so that's why it is such an effective tool to screen, because we're not talking about local, regional, distant. We're talking no cancer at all, but could become cancer. And so when we do colorectal cancer early at the appropriate age, and by the way, for Blacks now it's 45, no longer 50, because we do know there is a higher incidence in Blacks than non-Blacks. It is an option for non-Blacks, but very strong recommendations. I won't get into it too much, but we want people to actually get to your colon cancer screening, to your colonoscopies, or whatever methods you're using. There is more than one, but you need to have your discussion with your doctor and get to these things, because we can catch this thing before it's even cancer.
And so that's
waiting, obviously, can get you into that whole category now of talking regional, distant, or local, where your chance of survival will start to decrease.
And so this is the whole point, Dr. Alabre, of why we're here today to really talk about the importance of getting back to care. And care is not just treatment when you don't feel good. There's a whole proactive routine, your yearly physical. In my case, I'm getting ready for the I'm 50, so there's a whole bunch of screenings I need to get ready to do, practicing what I'm preaching. But also, getting, if you have some other existing issues, you got to get your routine blood tests. Sometimes if you're on certain meds, they want to check your levels and make sure that everything is good. And so it is important to actually go and get back to care. I just wanted to reiterate that's why we're here today. But just in general, this is why we have your Healthy Java. Are you ready for the next one, sir?
Sure. Okay, so this is talking about something we know a lot of, we hear a lot about, breast cancer. Again, just to give more examples, the idea is still the same, that, catching these things early can make a difference. And so in the case of breast cancer, this is your survival chance, your chance of being alive at 5 years compared to someone who doesn't have cancer. It's about 99% if it's localized. Again, with the caveat that the type makes a difference, but when you look at all of them, when it's localized, 99% chance of being alive at 5 years, it drops to 86%. If it's regional, it starts to spread, it goes beyond that original start site, and it drops to 28% if it's distant. Now, if it starts to go to other parts of your body, to lymph nodes and other places. And so a little bit better than cervical cancer, but still a huge difference from 99 to 28% chance. And so we don't want, again, anyone to wait till you possibly show up to care when it's already distant, because you've actually really not done yourself a favor when it comes to treatment, management, and survival, which really matters, obviously. And so just more examples of the same.
Thank you. Thank you. I just want to interject for 1 second, Dr. Alabre, and let folks know it's being requested. I don't think Dr. Alabre you're not a PCP, are you?
I am.
You are a PCP, so you have so we'll share information in a few minutes of how you can contact Mass General Hospital if you're looking for a primary care physician. But I just wanted to note that because I saw it popping up a couple of times. We're also going to get to our questions in just a few seconds. And so I'll go to next slide, Dr. Alabre.
Sure. Yep. So again, this is the disclaimer I sort of mentioned from the beginning, that the numbers don't take everything into consideration. These percentages we give you, it's not all about early detection. It also matters how old you are, what type of cancer you have. In this case, for breast cancer, what kind of receptors there are on there. Again, we don't need to go into details, but I just want to make sure that people understand it's not just about detection. I don't want anyone to think, well, if it's early, I'm definitely going to be pretty good, because there are other factors. But the point we're making today is that timing matters, and we showed you overall how that changes with time.
Thank you. And I believe this is the last slide.
It might be.
Yep.
Yeah, perfect.
We're going to get ready to go into some questions, but I want to jump to this question first because you were talking about early detection. And so Heidi Ivy from Boston is asking, should we still perform self-examination?
That is a really tricky question. So, and I'm assuming this person is referring to breast.
I believe so.
Okay. I'd like to defer that to the breast cancer experts, to tell you the truth. And I hope at some point we would have someone there because it is controversial. And not being an expert, I don't want to get into controversies. And so we do have different bodies that make recommendations on these things. I would encourage people to look at the American Cancer Society website. There's lots and lots of information there. There's also the U.S. Preventive Task Force website that also makes recommendations on all cancer screening. Every types of cancer is on there. And so sometimes, unfortunately, there can be a little bit of difference between what the American Cancer Society says, what the U.S. Preventive Task Force says, and what the specific area of cancer, such as the obstetrics and gynecology, breast cancer societies. And so these things require discussion with your doctors. And I really encourage everyone to bring this up to your doctors that you should be going to regularly, and see what works best for you. One of the concerns, I'm not evading the question, it really just is a complex answer that I don't want to get into, but there are risks about concerns, at least, about sort of causing too much anxiety, unnecessary anxiety from detecting something, feeling something that may not be cancer, or not doing it correctly. And so it is somewhat of a tailored approach, depending on the person and their comfort level and their history. And so there are just too many factors for me to make a blanket statement on that right now.
Dr. Alabre, thank you. And she did confirm in the comments, I'm not showing it here, but she did confirm she was specifically talking about breast cancer.
Mm-hmm.
One of the other questions from Boston as well, from Quincy Roberts in Dorchester in Boston. Should I get the booster shot if I'm overall healthy with 0 preconditions?
Yes, that's what the science is telling us.
Absolutely. Yes.
Yes.
So that one's right in the case. Yes.
So yes, with a caveat, I should add. So again, because of supply and demand, there are restrictions, or at least recommendations, guidelines as to who should get it first and second and third. And so we do know for everyone, your protection decreases over time after the previous, the first 2 vaccines for Pfizer and Moderna. These are the ones we started out with 2 shots. And so, but it doesn't drop to 0 at this point yet. We don't believe it's 0. And if your risk of getting severely ill or dying from COVID is lower, the CDC, out of social justice considerations, recommends that only higher risk people get it. So people who are at high risk based on age or medical conditions, and people who are at high risk of contracting the virus because of occupational exposure. So teachers, grocery store workers, doctors and nurses and things like that. And so, so we are following that again out of because of supply and demand, and that may change over time where it's opened up to everyone. But as of right now, the CDC has given the green light for anyone over the age of 18 to receive the Johnson & Johnson vaccine to get a booster. Okay. So it doesn't matter if you're healthy, if you're sick, if you're old or young, anyone over the age of 18, if your vaccine so far has been the Johnson & Johnson, it's recommended that you get a booster. And that booster should be either Moderna or Pfizer, preferably, because the boosting effect benefits from getting a second Johnson & Johnson is not as robust. And so we are advising people to go with Pfizer or Moderna for your second.
For their booster. Okay. And I'll just say this is no opinion of Mass General Hospital or anything, but I would say the Johnson & Johnson is what gave me pause. And so I can see, and there's been a lot of conversation about, can you sort of, for layman's terms, mix, the different vendors vaccine, but right now you're saying
yes, the CDC, that's the recommendation. This is what's approved. This is what's been looked at. It's been studied. Yes, if you got Johnson & Johnson, actually mixing and matching is okay. There's no harm as far as we know from the data, and the CDC, it's all on their website. You can. It is somewhat of a light recommendations. If you got Moderna or Pfizer, you can stick with that. But for Johnson & Johnson, the recommendation is to go with Moderna or Pfizer and boost regardless of risk of age, as long as you over the age of 18, since that's the only one it was approved for anyway. So these are the people who would have gotten Johnson & Johnson.
This is very important because I will name that I was aware in a lot of the communities I'm a part of is that folks were making a decision, and Johnson & Johnson was the one shot. And so folks didn't have to worry about going back and get the second one. And so there were a lot of people in my community that I know got Johnson & Johnson. So he's saying now, if you got the Johnson & Johnson, if you're over 18, get you a booster, contact your doctor. And this is good to go right to Cindy Diggs' question, our sort of project coordinator, liaison, something from Mass General as well. And this is the wrong one. I should have went to Cindy's question. Okay, where is it? Cindy was asking, where can people go to get a booster shot?
Lots of options. So currently, CVS and Walgreens are doing really well with getting people boosters. And I have to say, it's fairly easy. I do not work for either company, so I'm not doing a commercial for them. But it is, I went through the process myself. And so basically go on their website and you pick what you're looking for. If it's the booster, and they ask some questions, obviously age and what you got the first time and all that stuff to make sure that it is appropriate for you. And then you get a calendar that just shows you all the open slots with all the days and the times, and you click on it and you confirm and you're good to go. You show up to the, and it's all covered by insurance or no insurance as far as I'm told. And so it's all free for everyone. And so you can go to either of those places. Obviously, lots of other options. A lot of hospitals are doing that. We are doing booster shots as well at MGH. Somewhat more limited, I can say, in terms of timing and scheduling because of volume and supply. But that's an option if that's where your doctor is. And other hospitals are also doing the same, and other clinics are doing the same. So you can contact your doctor, your clinic, wherever you go first and see what's available there. If not, you can just, again, go to CVS or Walgreens, or actually still the state website, mass.gov, has a huge section on COVID vaccines and boosters that also has information on scheduling and where to get those. So that information is out there. And it's relatively easy, from what I understand, for people to get if you just look.
I just actually saw a comment where someone said, this wonderful tech, wicked easy. Jen from Boston, true Bostonian, wicked easy, Walgreens, huge shout out. And so we're not doing commercials. And if you would like to support the work that MGH and Java with Jimmy is doing, if you're a representative from Walgreens, at this. But the other piece I wanted to name, and Pops Davis is also mentioning, is there a time gap that should be observed from the date of the second vaccine to scheduling the booster?
Yes.
A very good question, Pops Davis.
Yes. So the guidelines right now is if you got Johnson & Johnson 2 months after that shot, you would get a booster. If you got,
again, because people are hearing 6 months if they got the Moderna and Pfizer.
6 months for Moderna and Pfizer.
Yep.
2 months for Johnson & Johnson.
Okay. All right. That's good.
Okay.
Yep.
So a minimum basically is the recommendation. It can be a little longer, obviously, but at least 2 months after Johnson & Johnson and at least 6 months after Moderna or Pfizer.
And Tony, that question is being answered right here. Tony, listening from Boston as well. That was just covered in that question. And Heidi Lewis was asking another question. And so is Natalie, kind of the same thing. Do you recommend getting the flu vaccine and the booster shot at the same time? And I just wanted to say before he answers, Dr. Alabre has not examined anyone. And so this information is being shared in a general, his medical awareness. And so the best thing you can always do, talk about getting back to care, is call your PCP. And I know a few folks named they did not have one, but well, as far as the PCP, I don't want to give them wrong information about where they should get their medical information from, but I know that is interesting as well as folks trying to get a primary care physician. But to their question, Dr. Alabre.
Yeah, sure. So the science is telling us they can be done at the same time.
In the same appointment, to be very specific.
Yes. Yes.
Really? So what about now this is James. This is in the comments. You know, there's you know, sometimes we get the flu shot either psychologically or real valid concern that, you know, we don't feel good. Then we get a booster. Now, you know, is there potential that within the 24 hours you getting a booster and a flu vaccine, is there a likeliness that you might not feel well? Let's just ask that.
Right. I don't have the reports to say if people are really feeling sicker from doing that. I do have the report that it is safe to do, and lots of people have done it. I haven't gotten any feedback. My patients have received them at the same time. And so it is not contraindicated. As far as we know, they work and people have been doing them. And there's even obviously talks if we were to go into a situation where the COVID vaccine booster is needed every year or so, they might even combine them in just one shot with both the flu and the COVID vaccine because it is safe to use together same day. So we do have that information.
One of the things I wanted to name, Dr. Alabre, and this is not sort of a medical assertion, but there's a lot of concern, a lot of conspiracies about this vaccination. And I think the difference is that we weren't around in the late 1800s and 1900s when there was a pandemic of chickenpox, when there was a pandemic of polio and whatnot. And so those folks live through this sort of approval process, maybe not as tech and, seeing real-time information on CNN. And so it causes a concern with people, but we get normal vaccines all the time. Varicella, AKA chickenpox, polio.
Right.
If you cut your finger and, you haven't had a tetanus shot lately, we get that. And so I just wanted to name that this science, again, we named it before, it's not new. And we've also had Dr. Fauci's research and stuff around for a long time with other, prior diseases, like when we had, the H1N1, the swine flu. And so there is some research to which this is based on. And so we are, wow.
I fully agree. Yeah, I wanted to, are there any questions about routine care and what hospitals are doing to keep people safe? I know I didn't get into that too much, but I would assume people are aware.
We don't have a lot of questions about routine care. I think what really people responded to was the screenings. And then a large part of the audience is filled with our, our seasoned sisters, I'll put it that way. And so when you started talking about breast cancer, that is where most of the questions came. And also, hi, Natalie, to Natalie's about the vaccine and the flu shot. So the bulk, all of the questions were answered today, Dr. Alabre, but the main piece was about you being a PCP. So let's share, because folks want to come and have Dr. Alabre be the PCP. How can folks contact and Natalie, if you're in the room, please put it in the comments and I'll show it if there's a website. How can folks contact Mass General if they're interested in primary care, getting a primary care physician? It may not be at the actual hospital, but there are satellites in Chelsea. There are satellites, I believe, throughout different parts of Greater Boston where there are primary care physicians. Of course, if you need certain procedures, and, the hub is Mass General, but there are a lot of affiliations. And then there's the overall Mass General Brigham, formerly Partners Network as well. So Natalie, or I can go do some research here, but I just don't want the
and there is a central office that works with people on finding them a PCP. And so there is a main number that you can call. You can also go on the massgeneral.com org website and get that information. And I can take a quick look too if I have the number. I can tell you.
You can go to Mass
Patient Referral Line.
And we'll put that in as well. We do this in real time, getting you
I know.
for your healthy Java. And basically the experience is you will call a physician, primary care physician referral line. They will get your information. They will ask about your insurance information. I presume they may ask, are you calling because there's an emergency, whatever. Always, if there's emergency, call 911. If you're having symptoms about things, call 911. But we will put the patient referral number in.
So the primary care physician referral service number is, are you ready?
Yes.
800.
Hold on. I did 617. Okay.
No, there is no 617. Yeah, it's 800 actually. Toll free.
Number, sir?
711.
Okay.
I got to start over here. So 1-800-711 4644.
4644. And of course, I hit 0 instead of the space. So, okay. We're smart.
So I'll confirm when you put it up that you have it correct.
Okay, 800-711-4644, correct?
That's correct, yeah.
Okay.
So that's the main line. That's the central office that, you got it, that will help you find a PCP. And that is for all the satellite clinics, Waltham, Chelsea, Revere, Everett. I mean, there's lots, and main campus, so they can work with you on what your needs are, your location, what's convenient. And unfortunately, I cannot say it is wide open. There is certainly, oh, not only got the same number. And so there is certainly a shortage, unfortunately, of primary care physician. But with a little bit of flexibility, we hope that we can get everyone in and certainly get you your care. And as we just talked about, it is important. Don't wait till you actually have symptoms. It makes a difference. And cancer screening is not the only thing we do. We didn't get into, obviously, diabetes, high blood pressure, kidney disease, all the chronic illnesses. Again, these do require routine checks. Things change. So first, we do screen for diabetes that someone who has not been diagnosed yet may not even know. And so that's part of the things that you would get by going to your doctor for routine care. But also, if you have these conditions, and I have lots of patients with diabetes and high blood pressure and kidney disease who have not been in to be seen because, again, of fear of possibly catching COVID by coming to the doctors. But these things actually matter. People's kidney functions can get worse over time. Your diabetes can obviously get worse, which can lead to lots of complications, heart attacks, strokes, and everything else. And so not knowing where you are after this long, again, a year and a half is way longer than we ever recommend someone not be seen, especially if you have chronic conditions. And so we're beyond that point. You really need to start to make your way back into care and hopefully catch these things that can turn into a heart attack or a stroke or kidney failure requiring dialysis. So the consequences are dire, and we don't want anyone to miss out.
Absolutely. Dr. Alabre, I have to ask this, and I know maybe not yet, but in talking with Dr. Betancourt, who was featured in the video earlier, I just wanted to name that. I know that MGH is working to have better reach in communities of color, in neighborhoods. So to Tony's question, I don't know how close to the hood. And if you're like me, you'll define the hood, RDM, JP, Lower South End, Roxbury. And so I'm not sure, do we have a satellite office or affiliated physicians in like Roxbury, Dorchester, Mattapan, and JP?
Not currently. JP is certainly close to the Brigham, and Brigham is part of Mass General
in Jamaica
Brigham umbrella. So we one institution technically, but not an MGH specific. And then we have Waltham, which is a little bit more out west. There's Newton Wellesley, which is also under the Mass General Brigham umbrella. And then we start to go a little bit farther southeast in Pembroke and Foxborough. So most of the Dorchester Mattapan is primarily now Boston Medical Center. Again, I am not advertising for any particular hospital. This is where I work, but your care is what matters. Get it where you can. We don't want anyone to
hold on, because that needs to be a I'm going to take one of your pictures and we're going to make a flyer. Healthcare matters. Get it where you can. Yes, sir.
That's I think that sounds really good, actually. Now that I've said it. No, really. I mean, it truly matters, and we would hate for anyone to miss out. And as I mentioned in the slide earlier, we know Blacks and Brown communities are at a disadvantage for lots of reasons, not because it's your fault, anyone's particular fault, but there are efforts being put into rectifying this. This is part of what we are doing at Mass General in terms of healthcare equity, is to really allow different groups to have access and get the right care and not be left behind.
Dr. Alabre, thank you. We're just a couple of seconds over time, but it is well worth it. And if you leave with nothing else, healthcare matters. Get it where you can. We just wanted to mention that our next session is going to be on Tuesday, November 23rd. That is the week of Thanksgiving. And I had the opportunity to interview Dr. Fatima Stanford, who is a medical doctor. And then a whole bunch of other credentials. I mean, a paragraph behind her name. And I say that lightly, but we also have to name the fact that she is a very astute and well-knowledged person, and she is an African-American that's going to come in and talk with us on the 23rd about healthy living. And we had a wonderful conversation about stress, sleep hygiene, eating, healthier ways. We talked about the comparison of the general BMI, which is the body mass index. And she did a paper. Listen, this is a good session today. Our first session was a good one, and they're going to get better and better. But I need you to plan to come in on the 23rd because we're going into the holiday season. And she talks with us just about a little bit about alcohol, about wiser ways to consume all the wonderful food that we like to eat during the holidays. And so that's taking place on Tuesday, November 23rd. And we want to remind you and let you know, beginning today, or 2 weeks ago, but 2 weeks from today, we are here every 2 weeks at 9 a.m. Dr. Alabre is my co-host / medical director, and we have experts that will be coming in to give you information for your health. That's why we call it Your Healthy Java. So don't forget, November 23rd at 9 a.m. We would love to see you here back in the room with Dr. Alabre, also with Dr. Fatima Stanford, and also Dr. Alabre, the nutritionist.
Yes.
We're going to have a nutritionist in the room, and you all will be able to ask now. You're not going to be able to come in about how you can substitute certain things for your macaroni and cheese, all specific, but you will be able to ask questions of the nutritionist because Dr. Stanford will not be able to be with us in real time. But we want to thank you for being with us today. These episodes are available in a few places, as I said before, always available to go and watch back on Twitter, always available to go watch back on Facebook, and also on YouTube at the handle Java with Jimmy. And pretty soon we will have this on one page on the Java with Jimmy website, one location where you can watch all of the episodes. And I think that's it for us today, Dr. Alabre. Is it?
That sounds good. I think so.
Okay, sir.
Yeah, it was great.
Your closing words, sir.
Yeah, I think I'll go back to the same thing. Healthcare matters. Get it where you can. That's my closing word.
Natalie, let development know.
And get it soon.
Listen, that slogan was created right here in the Java Cafe. Healthcare matters. Get it with Dr. Alabre. That was good. We will see you in 2 weeks. I'm going to stick around and just do a couple of more announcements. I know you have to probably go see patients, but thank you so much for today's session. I learned so much, and I'm sure that the audience did as well. Thank you, sir.
Thanks, everyone, for listening. We'll see you soon.
Appreciate you.
All right.
Everyone, that was Dr. Alabre. And as we do every two weeks, we come in on Tuesday at 9 a.m. to talk with him and other medical experts about Your Healthy Java. I just wanted to mention a couple of announcements. The first one is that please remember that we're going to be together on Saturday, November 27th at 11 a.m. at the Underground Cafe and Lounge in the South End with my good friend and sister, Nia Grace, who is the owner there. She's actually going to be with us on the 23rd as well at 10 a.m. Dr. Alabre will be with us at 9 a.m. She will be with us at 10 a.m. And then on the 27th, we're going to gather at the Underground Cafe and Lounge. We also wanted to let you know when he was in the room this morning that Brother Quincy Roberts, who's the new liaison for the LGBTQI plus community here in Boston, is currently conducting a survey and listening sessions to hear about your concerns as a member of the community, as an ally, as an offspring of a senior, or as a parent of a child who's a part of the community. He wants to hear from you. So you can go to that link. It is case sensitive, and fill out the survey. They are at about their goal of 500. And so please remember to go do that. And lastly, Thursday at 9 a.m., Mayor-elect Wu will be here in the Java Cafe. Mayor-elect Michelle Wu is coming in. She came during the campaign. She came the morning after the preliminary where she was top billing. We were not able to get her in on November 3rd because so much had happened. And she's been in other platforms and places, but she's coming here to the Java Cafe on screen. And we're going to talk with her just about her experience so far, what it is she's going to do the first 100 days. And remember that there is a website called All Aboard Boston. If you're interested in being a part of the transition team, please go and check out that website. That's it for me today. Today's Tuesday, so I will not see you guys until tomorrow at 9 a.m. here in the Java Cafe for We Need to Know Wednesdays. Have a wonderful day, everybody, and we'll see you tomorrow at 9.